It's a pleasure to be with you. The title of this session is COVID-19 Part 1, History, Characteristics, and Mitigation Concepts. There are no disclosures for this presentation. Objectives include review coronavirus history, review COVID-19 characteristics, discuss 6 concepts to flatten the curve, review the 12 social distancing recommendations, review COVID-19 testing concepts, isolation guidelines, and immunity. There are 3 phases to the COVID-19 pandemic: the pre-vaccine phase, post-vaccine phase, and endemic phase. The pre-vaccine phase focused on learning about the organism and disease, decreasing transmission, and protecting vulnerable individuals. As with most public health situations, strategies need to flex, evolve, and adapt as new information is gathered and analyzed, and as pandemic response tools are developed and deployed, like COVID antiviral medications and vaccines. Let's spend a few minutes learning about the COVID organism and disease. Coronaviruses are a large family of viruses that cause diseases in mammals and birds. Symptoms of coronavirus vary from species to species. Chickens often have upper respiratory symptoms, and cows and pigs diarrhea. Human disease manifests generally as a respiratory infection. Coronaviruses are enveloped viruses with a single-stranded RNA genome and nucleocapsid. The name coronavirus is derived from the Latin word corona, meaning crown or halo, which refers to the characteristic appearance of a crown around the virus particles when viewed under two-dimensional transmission electron microscopy. Human coronaviruses were first discovered in the late 1960s. There are 7 strains of human coronavirus currently known. 4 of these strains generally produce mild symptoms of the common cold and include human coronaviruses OC43, HKU1, NL63, also known as the New Haven coronavirus, and 229E. These 4 strains continually circulate in the human population and cause respiratory infections in adults and children worldwide. 3 strains are associated with more severe and even lethal disease associated with pneumonia, including severe acute respiratory syndrome coronavirus, SARS-CoV, also known as the SARS classic virus, seen in 2003. The Middle East respiratory syndrome coronavirus, MERS-CoV, causing outbreaks from 2012 to 2018, and the recent cause of COVID-19 disease, severe acute respiratory syndrome coronavirus 2, SARS-CoV-2, previously known as 2019 nCoV or novel coronavirus 2019, can cause both upper and lower respiratory disease. During this session, I will use the term COVID-19. In December 2019, SARS-CoV-2 outbreak was first reported in Wuhan, China. The SARS-CoV-2 virus has a 70% genetic similarity to the SARS-CoV virus from 2003. SARS-CoV-2 is thought to originate from bats, since the virus has a 96% genetic similarity to a bat coronavirus. The mortality rate of SARS-CoV in 2003 was approximately 10%. MERS mortality has been as high as 30%. The mortality rate worldwide of SARS-CoV-2 as of March 20th, 2020 was 4.2% of those with confirmed infection. In the United States, the mortality rate of SARS-CoV-2 on March 20th was 2.1%. This slide lists a few of the many coronavirus variants that have emerged around the world. Viral mutations are common and have occurred with COVID-19. It's estimated that COVID-19 acquires about one new genetic mutation every 2 weeks, according to the CDC. Let's review some of the observations and concerns expressed as these variants emerged. A more contagious and lethal coronavirus alpha variant, B.1.1.7, was first identified in the United Kingdom. The alpha variant included several mutations that affected the spike protein on the virus surface. Those spike protein mutations enhance the attachment of COVID-19 to human cells, therefore increasing the transmissibility of the virus. It was estimated that the COVID-19 alpha variant or mutation was approximately 70% more transmissible than the original virus. A recent study reported in the British Medical Journal found that individuals infected with the alpha or UK variant were 64% more likely to die than equivalent individuals infected with previous circulating variants. Researchers said deaths due to the alpha variant increased from 2.5 to 4.1 per thousand detected cases. COVID-19 vaccines were protective against B.1.1.7. A variant known as Beta or B.1.351 or 501YV2 was described in South Africa and was of concern since it was partially resistant to antibodies to the original COVID-19 strain. A surge in cases in Brazil was attributed to a more transmissible P1 variant of the coronavirus, also known as the Gamma variant. Brazil's health minister claimed this variant was 3 times more transmissible versus the original strain. The new P1 variant was able to infect between 25 to 61% of people who had previously been infected and expected to be immune. Via a laboratory study, the Pfizer vaccine was effective against the P1 variant. The Delta variant was first described in India and is also known as the B.1.617 variant and circulated around the globe. The Delta variant was 40 to 60% more transmissible when compared to the highly transmissible Alpha variant. There was a reduction in vaccine efficacy against the Delta variant, particularly after the first dose of the Pfizer mRNA vaccine, 15 to 20%. Efficacy against hospitalization after the first dose was around 70%. Efficacy remained high, 95%, after the second dose against hospitalization, similar to the efficacy against the original COVID-19 variant. So once fully vaccinated, the mRNA vaccines still worked to prevent severe disease with Delta, underlining the importance of being fully vaccinated. Let's briefly discuss current information on the Omicron variant. It appears that the Omicron variant is much more transmissible versus Delta. This is likely due to the marked increased replication of Omicron virus versus Delta, with approximately 70-fold increased viral particles in various respiratory secretions. This increased transmissibility caused marked spikes in cases around the world and was much more likely to cause infections in households than Delta. One study suggests household transmission with Omicron increased by 3.2-fold over that with Delta. This graph demonstrates the rapid rise of cases due to Omicron in South Africa, with similar case rates noted in many other countries around the globe. This graph shows the increased incidence of Omicron infection in individuals under 55 years old, and particularly in those 18 years old and younger. Viral mutations of the Omicron variant resulted in a significant loss of viral neutralization after a previous COVID infection, or even after vaccination, therefore resulting in increased reinfection risks. So prior infection with COVID does not seem to provide neutralizing antibody protection for Omicron versus other variants. These graphs, E, F, and G, demonstrate laboratory convalescent neutralizing antibody activity after a previous COVID infection with other variants against Omicron. As demonstrated, there's almost no neutralizing activity of that post-natural infection convalescent antibody against Omicron. Graph H demonstrates the significant neutralizing antibody activity against Omicron of super-immune individuals like those receiving booster doses of COVID vaccine. Though possessing greater transmissibility, Omicron disease may present with less severe disease and less deaths and hospitalizations from initial studies in South Africa, even with increased case rates. The highest hospitalization rates with Omicron are seen in those less than 5 years old and greater than 60 years old. Booster doses of COVID vaccines dramatically increase neutralizing antibody and protection against symptomatic infections. Boosters likely provide 76% protection against infection and 85 to 90% protection against severe disease. New variants have been identified: BQ1, BQ1.1, and XBB. The BQ1 and BQ1.1 variants are highly immune evasive, meaning that monoclonal antibodies don't work well against them. BQ1.1 is thought to be the most immune evasive variant and is surging in some areas of the world and the United States. Another variant of concern is XBB, a combination of two Omicron strains currently spiking in Singapore and Bangladesh. The main point is that additional coronavirus variants with new characteristics will likely continue to emerge and challenge public health. This slide lists two major points regarding variants. 1. Get fully vaccinated. 2. These highly transmissible variants underline the importance of using the primary prevention measures of masking, social distancing, and hand washing to help slow the spread of COVID-19. These next few slides cover some key information about COVID-19 disease. The incubation period of COVID-19 is 2 to 14 days, with a median of 5 days. The incubation period is the time from when a susceptible person is exposed to a disease until they develop the disease. COVID-19 transmission, or the contagious period, occurs early in the course of the illness, generally from 1 to 2 days prior to the onset of symptoms to 2 to 3 days after onset of symptoms. For some infected individuals, particularly those who have severe disease or are immunocompromised, the duration of viral shedding can be longer. This table is a comparison of the incubation periods and serial intervals of SARS, MERS, and COVID-19. The median incubation periods and range are similar for all three of these coronaviruses, between 4 to 6 days with a range of 2 to 14 to 16 days. The serial interval is the time between detecting the first and second cases. For SARS and MERS, the serial interval is longer than the median incubation period, where it is less than the median incubation period for COVID-19. Of these three coronaviruses, COVID-19 is the only one that is infectious before the onset of symptoms, which enhances transmission and may help explain why COVID-19 became a pandemic. Symptoms of COVID-19 disease include fever or chills, cough, shortness of breath or difficulty breathing, fatigue, muscle or body aches, headache, new loss of taste and or smell, sore throat, congestion, runny nose, nausea, vomiting, and diarrhea. This is a graph of signs and symptoms of COVID-19 patients from China. Fever was the most common symptom, followed by cough, myalgia, arthralgia, headache, and diarrhea. Though there is no set of signs or symptoms that can reliably discriminate COVID-19 from other viruses, anosmia or loss of smell and dysgeusia or loss of taste are more common in COVID-19. Individuals with symptoms listed on this slide should seek medical care immediately. Trouble breathing, persistent pain or pressure in the chest, new confusion, inability to wake or stay awake, and bluish lips or face. It's currently felt that up to 25 to 40% of those infected will be asymptomatic, but still able to transmit the infection to others. This fact underlines one of the difficulties encountered when attempting to contain this virus. Individuals who are elderly, over 60 years of age, and any individuals with certain underlying medical conditions are at greater risk of severe disease. Though the elderly are at greater risk of severe disease, severe illness is also seen in young people. Underlying medical conditions that place a person at greater risk of severe disease and death include lung disease, cancer, heart failure, cerebrovascular disease, renal disease, liver disease, diabetes, immune compromise, and pregnancy. These next two slides describe a few demographic risk factors for the early part of the pre-COVID vaccine phase. This table provides the adjusted odds ratios for characteristics of hospitalized COVID-19 patients in metropolitan Atlanta, Georgia, from March to April 2020. Age over 65 was associated with the highest odds ratio for hospitalization, followed by being Black, having diabetes, being non-insured, male, a smoker, and being obese. This table, published in the Lancet Infectious Disease Journal, demonstrates the risk for hospitalization and death per 100,000 infected patients per age group. There is a progressive and dramatic increase in hospitalizations and death with age. In the 80-plus age group, 9.3% of those infected with COVID-19 will die. This table reviews the reports of two studies associating blood type with severity of illness in COVID-19 patients. The New England Journal of Medicine article reported the findings of 1,600 patients hospitalized with severe cases of COVID-19 in Italy and Spain. Type A blood was associated with a 45% increased risk of having severe COVID-19 and having type O blood was associated with a 35% reduced risk of severe disease. A study of 2,173 COVID-19 patients from 3 hospitals in Wuhan and Shenzhen, China, also demonstrated a similar association, with a 21% increased risk of severe disease with type A blood and a 31% decreased risk with type O blood. A Columbia University study of 1,559 patients looked at the association of blood type with COVID-19 infection in general, not just severe disease. The infection rate was 34% higher in patients with type A blood and 20% lower for those with type O blood and 44% lower in those with type AB blood, though there were only 21 people with AB blood in the study group. While everyone is at risk of getting COVID-19, some people may be more likely to get COVID-19 or experience severe illness. This graph shows the age-adjusted hospitalizations for COVID-19 based on race and ethnicity. Hispanic and Latino rates were highest at 425.9 age-adjusted hospitalizations per 100,000 population, followed closely by non-Hispanic American Indian Alaska Natives at 415.5 and non-Hispanic Blacks at 405.1. Non-Hispanic Asian and Pacific Islanders had an age-adjusted hospitalization rate of 127 and non-Hispanic whites of 100. Researchers in London suggest that there are 6 clinical severity indicator categories. The 6 categories could help with clinical management and matching patients with appropriate clinical care. Category 1 patients presented with headache, loss of smell or anosmia, muscle pains, cough, sore throat, chest pain, but with no fever. Category 2 patients presented with headache, loss of smell, cough, sore throat, hoarseness, loss of appetite, and fever. Category 3 patients had headache, loss of smell, loss of appetite, sore throat, chest pain, no cough, but also had gastrointestinal symptoms of diarrhea. Category 4 patients had headache, loss of smell, cough, fever, hoarseness, chest pain, and fatigue. Category 5 patients had headache, loss of smell, loss of appetite, cough, fever, hoarseness, sore throat, chest pain, fatigue, muscle pain, and confusion. Category 6 patients had essentially every symptom, including respiratory with shortness of breath and gastrointestinal symptoms. Category 6 symptoms included headache, loss of smell, loss of appetite, cough, fever, hoarseness, sore throat, chest pain, fatigue, confusion, muscle pain, diarrhea, abdominal pain, and shortness of breath. 16% of Group 1 patients were admitted to hospital. Almost half of those in Group 6 were hospitalized. They also found that patients in 4, 5, and 6 categories tended to be older and were more likely to have pre-existing conditions ranging from diabetes to obesity. Normally, there is a balance between immune stimulation and regulation during infection with viruses like COVID-19. Immune stimulation and regulation are dependent on a variety of cellular, antibody, and other immune processes of innate and adaptive immunity and their interactions, including the incredible influence of a variety of cytokines on the immune response to infections. When stimulation of the immune system is not in balance or appropriately regulated, it can result in a catastrophic immune response that can severely damage and even kill the infected individual. This situation of excessive immune stimulation of the immune system is called cytokine storm, since cytokines play a major role in this process. This imbalance of immune stimulation versus regulation is associated with COVID-19 risk factors, severe disease, and death. Let's spend a few minutes discussing a few lifestyle factors and their potential impact on COVID-19 disease. These lifestyle factors are things people can choose to address and may help decrease their risks for severe COVID disease and death. As previously mentioned, an individual who smokes has a 2.3 odds ratio for hospitalization when infected with COVID-19. These individuals should be encouraged to stop smoking and engage in tobacco quit programs and support services. These next few slides review a few interesting observations and recommendations from experts in the fields of fitness and sleep. Additional research is needed on lifestyle factor immunology. Many lifestyle factors may cause immune dysfunction, including obesity, inadequate exercise, sleep disorders, and chronic physical, social, and emotional stress, anxiety, and depression. Also, as previously mentioned, an individual who is obese with a BMI of 30 or higher has a 1.9 odds ratio for hospitalization when infected with COVID-19. Obesity seems to be associated with immune dysregulation, resulting in a chronic increase of systemic inflammation associated with enhanced cytokine activation. Obesity-associated immune dysregulation also manifests with decreased antibody responses to viral vaccines like influenza, and also is associated with increased viral shedding and duration of infection in individuals infected with viruses like influenza. This may partly explain the increased severity of COVID-19 in obese individuals. So controlling weight through an adequate balanced diet can help improve immune responses to viruses and vaccines. Adequate exercise can also impact healthy weight and is linked to additional immune benefits. Within minutes of exercise, an increase of cells of the innate immune system, including monocytes, neutrophils, natural killer cells, etc., are detected in the blood and subsequently enter tissues ready to respond as the first line of defense against infection. 2 to 3 hours after exercise, the blood levels of circulating innate cells return to pre-exercise numbers, but the innate cells that were distributed to tissues remain in those defensive positions. Individuals who moderately exercise 150 to 300 minutes per week increase their ability to defend against and respond to viruses. Studies have shown that individuals who moderately exercise have 40 to 50% less upper respiratory tract infections versus sedentary individuals. Individuals who heavily exercise, like marathon runners, have a 2 to 4-fold increase in upper respiratory tract infections versus sedentary individuals. So excessive exercise is not immunologically beneficial, but detrimental. Physically fit individuals who regularly exercise have a risk of death from viral infections 52 to 54% less than sedentary individuals. Fit elderly women have a 56% greater T-cell function versus sedentary individuals. So individuals, even the elderly, may benefit immunologically from regular moderate exercise. Reasonable COVID-related exercise recommendations from experts include: don't over-exercise. moderately exercise about 150 to 300 minutes per week. When infected with COVID-19, don't exercise until asymptomatic and at least 2 weeks after COVID was diagnosed. When reinitiating exercise after COVID infection, slowly increase exercise intensity until reaching the moderate level of 150 to 300 minutes per week. Individuals with sleep disorders like insomnia express immune dysregulation, including enhanced chronic inflammation, reduced response to viral infections, and reduced response to vaccinations. Cognitive behavioral therapy and meditation-associated therapies like mindfulness training and Tai Chi have been shown to reduce sleep disorders and immune dysregulation with its associated chronic inflammation. Cognitive behavioral therapy is not readily available to most of the population. Meditation programs like mindfulness and Tai Chi are much more available to the general public. Using meditation as primary versus secondary or tertiary prevention seems reasonable. Chronic physical, social, and emotional stress, anxiety, depression, etc., are often associated with sleep disorders and immune dysregulation. These are common conditions of individuals working long hours under trying conditions like those of first-line workers during the pandemic. These individuals need appropriate support services to effectively deal with these issues. So reducing lifestyle immune dysfunction may be helpful in decreasing susceptibility to COVID-19 disease severity, death, and vaccine efficacy, and should include adequate balanced diet, regular moderate exercise, adequate sleep, and meditation. Let's spend a few minutes discussing COVID-19 inflammatory disease and Kawasaki disease in children. Let's start with a brief summary of Kawasaki disease. It's also known as mucocutaneous lymph node syndrome because it affects the skin, the mucous membranes inside the mouth, nose, and throat, and causes lymph node enlargement during an infection. Kawasaki's disease is a rare disease that causes inflammation in the walls of medium-sized arteries throughout the body, including the coronary arteries, which supply blood to the heart muscles. Kawasaki's disease is most commonly seen in children under 5 years old, with boys slightly more at risk than girls. Children of Asian or Pacific Island descent have higher rates of Kawasaki's disease. Cases of Kawasaki's disease, while rare, do appear to rise in springtime and in the fall of the year. The etiology of Kawasaki's disease is unknown. A number of theories link the disease to bacteria, viruses, or other environmental factors that stimulate a vigorous autoimmune response in these children. Kawasaki's disease signs and symptoms usually appear in 3 phases. Signs and symptoms of the first phase may include a fever that's often higher than 102.2 degrees Fahrenheit or 39 degrees centigrade and lasts for more than 3 days. Conjunctivitis or red eyes without discharge. Red, dry, cracked lips and an extremely red, swollen tongue. A rash on the body and in the genital area. Swollen red skin on the palms of the hands and the soles of the feet. Swollen lymph nodes, particularly in the neck, but also can be seen in other parts of the body, and irritability. The second phase of the disease is associated with peeling of the skin on the hands and feet, especially the tips of the fingers and toes, often in large sheets, joint pain, diarrhea, vomiting, and abdominal pain. During the third phase of the disease, signs and symptoms slowly resolve unless complications develop. It may take up to 8 weeks before energy levels return to normal again. A major complication associated with Kawasaki's disease is the involvement of the heart. Kawasaki's disease is a leading cause of acquired heart disease in children. However, with effective treatment, only a few children suffer lasting damage. Heart complications include inflammation of blood vessels, usually the coronary arteries that supply blood to the heart, inflammation of the heart muscle itself or myositis, and heart valve problems. Inflammation of the coronary arteries can lead to aneurysms or bulging of these arteries. These aneurysms increase the risk of blood clots, which can lead to a heart attack or cause life-threatening internal bleeding. For a very small percentage of children who develop coronary artery problems, Kawasaki's disease can cause death, even with treatment. Treatment generally consists of the administration of gamma globulin intravenously, which has been shown to decrease the risk of coronary artery complications. High doses of aspirin may help treat inflammation. Aspirin can also decrease pain and joint inflammation, as well as reduce the fever. Kawasaki's treatment is a rare exception to the rule of not using aspirin in children. Aspirin has been linked to Reye's syndrome, a rare but potentially life-threatening condition in children recovering from chickenpox or flu. Treating Kawasaki's disease within the first 10 days of onset may greatly reduce the chance of serious complications. Signs of Kawasaki's disease, such as high fever and peeling skin, can be frightening. The good news is that Kawasaki's disease is usually treatable, and most children recover from Kawasaki's disease without serious problems. With Kawasaki's disease in mind, let's consider COVID-19 inflammatory disease in children. Children have largely been spared from severe COVID-19 disease or complications. Britain's National Health Service first noticed a small rise in children infected with the coronavirus that exhibited features similar to toxic shock syndrome and atypical Kawasaki's disease. This syndrome is now seen in other countries, including France and the United States. The New York State Department of Health has labeled this the pediatric multisystem inflammatory syndrome potentially associated with COVID-19. Some of the children with this new syndrome initially had negative COVID-19 PCR tests, but later tested positive for antibodies. Children with COVID-19 inflammatory disease range from 2 to 18 years old, with most being teenagers. Kawasaki's disease generally affects children under 5. Patients often present with a sudden drop of blood pressure or shock and myocarditis that results in a sudden decrease in heart muscle function. Along with myocarditis, they also manifest gastrointestinal and respiratory symptoms. Respiratory symptoms are generally not as dramatic or severe as those seen in adults with severe COVID-19. Generally, the patients have had favorable outcomes, though some needed intensive care. It could well be that this virus drives the same inflammatory response similar to Kawasaki's disease. This childhood manifestation of COVID-19 seems to be similar to the abnormal immune response or cytokine storm observed in adults with severe COVID-19 disease. Treatment for this disease may, like Kawasaki's disease, include IV immune globulin and anti-inflammatory drugs like tocilizumab, an interleukin inhibitor that decreases inflammation. Let's spend a few minutes discussing POTS syndrome and COVID-19 infections. Postural orthostatic tachycardia syndrome, or POTS, can be triggered by a variety of conditions, including nerve damage, hormones, low blood volume, autoimmune disorders, bacterial or viral infections like COVID-19, etc. POTS signs and symptoms include severe fatigue, lightheadedness, brain fog, memory problems, shakiness, headaches, spiking pulse rate with minimal or mild physical activity, and chronic nausea and vomiting. Recent reports indicate that 2 to 14% of coronavirus disease 2019 survivors develop POTS, and 9 to 61% experience POTS-like symptoms such as tachycardia, orthostatic intolerance, fatigue, and cognitive impairment within 6 to 8 months of severe acute respiratory syndrome coronavirus 2 infection. The autonomic nervous system regulates functions we don't consciously control, such as heart rate, blood pressure, sweating, and body temperature. Malfunction in any of these areas can produce symptoms that can be shared by numerous conditions, including POTS. Physicians not familiar with POTS may dismiss symptoms as lingering effects of COVID-19 or psychological imbalance. POTS can be very debilitating and requires specific treatment, so an accurate diagnosis is vital. There is no one standard treatment approach to post-COVID patients with POTS-like symptoms, and treatment should be personalized based on the diagnosis. If POTS is confirmed, treatment may consist of postural interventions, including moving slowly into an upright position, avoiding standing for long periods of time, and lying down and raising legs when having POTS symptoms. Aggressive hydration by drinking plenty of water is important. Regular exercise improves heart health and strengthens leg muscles to help push blood back toward the heart. Wearing compression clothing can also help improve blood flow. Dietary modifications may include increasing salt intake under a clinician's supervision and avoiding alcohol and caffeine. If these treatments aren't effective, medications may be prescribed and include those to decrease heart rate, like beta blockers, constrict blood vessels, like midodrine, or increase blood volume by reducing salt loss in the urine, like fludrocortisone. Physical therapy is also key, but patients need to respond to treatment sufficiently before starting a physical therapy program. Let's now discuss a few additional COVID-19 attributes. Transmission is primarily by respiratory droplets and aerosols. Respiratory droplets are larger particles that tend to drop out of the air relatively quickly. The dissemination of large droplets from infected individuals may be reduced by the use of masks. Aerosols are smaller particles that remain suspended in the air for a longer period of time and are not as easily removed by masks as are the larger respiratory droplets. This information underlines the importance of appropriately using masks and covering coughs or sneezes, particularly when ill, not only to help reduce COVID-19 transmission, but also reduce the transmission of other respiratory pathogens. According to a new study from the National Institutes of Health, CDC, UCLA, and Princeton University, scientists in the New England Journal of Medicine report that severe acute respiratory syndrome coronavirus 2, SARS-CoV-2, or the COVID-19 virus, was detectable in aerosols for up to 3 hours. It was also detectable for up to 4 hours on copper, 24 hours on cardboard, and up to 2 to 3 days on plastic and stainless steel. These results suggest that people may acquire the virus through the air and after touching contaminated objects. Therefore, the cleaning and disinfection of potentially contaminated surfaces, as with other respiratory pathogens, is important. There are several disinfectants that are active against coronavirus. A few of them are listed on this table and include household bleach solution mixed with water in the formulas provided, alcohol sanitizer containing at least 70% alcohol. This concentration is higher than the 60% recommended for a hand sanitizer. Ammonia solution, a combination of hydrogen peroxide and peroxyacetic acid, octanoic acid, etc. For a complete list and recommended contact times, please visit the Environmental Protection Agency website listed on this slide. Pets do not appear to pose a significant risk of transmitting the COVID-19 infection to humans. Reinfection can occur after natural infection and vaccination. COVID-19 has had broad-ranging impacts across many sectors of society, including outpatient clinic visits and vaccinations. In April 2020, outpatient visits had been reduced by 70%. One of the hardest hit specialties was pediatrics, with a 47% decrease. As of July 2020, the number of outpatient visits had increased, but is still well below pre-COVID levels. Along with the decline in pediatric visits, a decrease in pediatric vaccinations has been observed. Vaccinations are an essential service for children and adolescents. The CDC has released interim guidance for immunization services during the COVID-19 pandemic, including administer all due or overdue vaccines according to the routine immunization schedule during the same visit. Implement strategies to catch all children up on vaccinations. Provide vaccines safely by using appropriate personal protective equipment and social distancing. Let's now discuss concepts to decrease transmission and protect the most vulnerable, developed during the pre-vaccine phase and adjusted throughout the pandemic. A major early goal was to assure adequate medical care for the moderate and severely ill. There was an urgent need to protect the hospitals and clinics' capacity to care for the ill, not only those with COVID-19, but also those with other medical conditions that continue with or without the pandemic. This slide lists 6 concepts to flatten the curve, including 1. Decrease general public transmission. 2. Understand the epidemiology of the pandemic. 3. Protect the most vulnerable. 4. Develop and distribute vaccine and therapeutic and prophylactic medications when available. 5. Utilize effective messaging strategies. And 6. Develop a triage plan. Before we discuss external interventions, let's briefly consider a few key internal hospital process considerations. This slide lists some key CDC recommendations for hospital processes during the COVID-19 pandemic. Hospitals should reschedule elective surgeries. They should also shift elective urgent inpatient diagnostic and surgical procedures to outpatient settings when feasible. They should limit visitors to COVID-19 patients and plan for a surge of critically ill patients by identifying additional potential space in their facilities to care for these patients, including emergency rooms and other patient care areas. To decrease COVID-19 spread within hospitals, COVID-19 patients and staff should be cohorted to a specific COVID-19 space or ward within the institution. Another consideration for flattening the curve to protect healthcare institutions during the COVID pandemic is developing policies to enhance protection of healthcare personnel. Due to the high transmission and concerns about potential impacts on the healthcare system of the Omicron variant, the CDC updated recommendations to enhance protection for healthcare personnel, patients, and visitors, and ensure adequate staffing in healthcare facilities. As demonstrated in the table, the CDC created recommendations for infected, vaccinated, or unvaccinated healthcare workers and those who are asymptomatic but exposed to be able to return to work. The conventional approach for a test-positive healthcare worker, either asymptomatic or mildly symptomatic, but improving, is isolation for 10 days or 7 days with a negative test. That policy can shift to a contingency approach of 5 days with or without a negative test if asymptomatic or mildly symptomatic but improving. In a crisis situation, healthcare workers may return to work at any time if asymptomatic or mildly symptomatic but improving. The conventional approach for healthcare workers who are asymptomatic but exposed to a COVID-infected individual is based on the vaccination status. If they are fully vaccinated and boosted, there are no restrictions if they test negative on days 2 and 5 to 7. For contingency and crisis situations, boosted healthcare workers have no work restrictions. For vaccinated or unvaccinated individuals, even if within 90 days of a prior infection, the conventional approach is for 10 days of quarantine or 7 days with a negative test. For that group, the contingency approach is no work restrictions with negative tests on days 1, 2, 3, and 5 to 7. For a crisis situation, the CDC recommends no work restrictions, but test if at all possible. Let's now consider decreasing general public transmission. These were recommendations during the pre-COVID vaccine period. A major tool to decrease viral transmission like COVID-19 in the general public is social distancing. This slide lists pre-vaccine COVID pandemic guidance adapted from CDC recommendations and includes 1. Stay home and don't go to work if you feel sick. 2. Wash your hands regularly with soap and water using at least a 20-second scrub time. If using hand sanitizer, be sure it contains at least 60% alcohol. 3. Avoid touching your nose, eyes, and mouth. 4. Cover coughs and sneezes. 5. If someone in the household has tested positive for COVID-19, keep the entire household at home. 6. Individuals over 60 years old and those with underlying health conditions should stay away from other people. 7. Work from home when possible. 8. Avoid social gatherings. 9. Avoid eating or drinking in bars, restaurants, and food courts. Use drive-through, pickup, or delivery options. 10. Avoid discretionary travel, shopping trips, and social visits. 11. Maintain at least a 6-foot distance between people. 12. Use a mask when in public. The CDC recommends that masks be worn by individuals in public settings for the following reasons. A significant portion of individuals with coronavirus are asymptomatic and can transmit infection to others. Also, individuals who eventually develop symptoms can transmit the virus to others before showing symptoms. The virus can be transmitted to people interacting in close proximity through speaking, coughing, or sneezing, even if those people are not exhibiting symptoms. Therefore, the CDC recommends wearing masks in public settings where other social distancing measures are difficult to maintain, especially in areas of significant community-based transmission. Even fully vaccinated individuals can become infected and transmit the infection to others. Fully vaccinated individuals have a lower risk of becoming infected than those unvaccinated. Wearing a mask is not an alternative to social distancing measures. Wearing a mask is not the most effective method to decrease the transmission of COVID-19, but may be a helpful adjunct to other social distancing practices. So particularly in times of increased community transmission, masks and social distancing should be used by both vaccinated and unvaccinated individuals to help control transmission. Flattening the curve means to use multiple interventions to decrease the number of patients requiring medical care for severe or moderate illness at any one time during the pandemic. This strategy will allow medical care systems to effectively operate within their capacity to adequately handle those needing hospital care. Also notice that pandemics and epidemics commonly present as multiple waves. Flattening the curve will tend to flatten and stretch out those waves. The term wave is often used in describing the spread of disease during epidemics or pandemics. In most instances, epidemic and pandemic spread acts more like bubbles, as illustrated in this outline of a North Dakota state map superimposed on a picture of a mud pot from Yellowstone National Park. These circles represent clusters of cases with surrounding waves of local spread. Using this type of epidemiologic data, along with known attributes of the offending organism, decision makers make strategic choices. In cases with widespread clusters, like illustrated here, and organism attributes suggesting very difficult or unlikely containment, like with COVID-19, widespread statewide interventions may be chosen. This illustration would likely be a common initial bubble pattern with highly transmissible novel viruses like COVID-19. In other cases, particularly where there are a few clusters and organism attributes and current epidemiologic data suggests the likelihood of reasonable containment, local interventions may be chosen. This illustration would likely be a common secondary or subsequent wave bubble pattern during an epidemic or pandemic. Let's talk about the importance of understanding the epidemiology of the pandemic and how that helps flatten the curve. Epidemiology relies on data to develop appropriate strategies. Testing to confirm true cases and their distribution is important in studying any epidemic or pandemic situation, including COVID-19. Testing helps identify and separate COVID-19 from other organisms that cause similar respiratory symptoms. It often requires a lot of testing to get a true picture of the epidemiology of a virus like COVID-19, particularly in the early stages of a pandemic. Epidemiology commonly gathers data to answer the who and where questions that guide decision makers toward how to respond strategies. For example, John Snow is considered the father of epidemiology. He was an anesthesiologist by training. He studied the cholera epidemic in London and identified the cause, contaminated water, associated with the Broad Street pump circled on the map. He gathered who and where data as seen on this map. Each dark mark is the physical location of a case of cholera. That information helped Snow deduce that the Broad Street pump was the geographic center of the epidemic and could likely be the culprit. Snow developed a how to respond strategy based on that data. In his situation, removed the pump handle, which Snow did. This picture is the famous Broad Street pump with the handle removed. That action resolved the cholera epidemic on Broad Street. Understanding the epidemiology of a pandemic like COVID-19 provides critical situational awareness for decision makers. Testing can identify when and where the pandemic organism arrives and indicate when and where to implement pandemic responses. Those responses may be applied locally to mitigate a cluster of cases, or in other instances, statewide or nationwide, dependent on the epidemic data and organism attributes. Testing can help determine when and where subsequent waves of the pandemic occur and when to discontinue pandemic interventions. Let's talk about the importance of COVID-19 testing for a few minutes. As we previously discussed, testing can help determine the epidemiology of COVID-19 and inform public health responses. Regular testing is essential for the test and trace strategy or contact tracing of cases. Testing is important clinically to determine the etiology of a respiratory infection. For example, it's important to identify patients with influenza that can be treated with drugs like Tamiflu or Zanamivir versus COVID-19 that may respond to monoclonal antibodies and antiviral drugs like Molnupiravir or Paxlovid and Ritonavir. Individuals testing positive for COVID-19 should have close follow-up to determine those that need to be hospitalized. Regular screening tests should be considered for multiple community venues, including community testing events in general, schools, businesses, healthcare, and long-term care facilities, etc. There are three categories of COVID-19 tests: molecular, antigen, and serology tests. Molecular tests identify the presence of viral genetic material. Antigen tests identify the presence of viral proteins. Molecular and antigen tests are diagnostic tests, meaning they are useful for determining current infection for both symptomatic and asymptomatic individuals. Polymerase chain reaction or PCR tests are the major molecular tests used to detect COVID-19. PCR tests require laboratory equipment and time to determine a result. Antigen tests don't require laboratory equipment and are often called point-of-care tests that can provide results in multiple community venues, including homes. Antigen tests provide results within minutes. Serology checks for the presence of neutralizing antibodies against the virus. It often takes at least a few weeks to develop an antibody response that can be detected, which means that by the time an antibody test becomes positive, the individual likely has already resolved their infection. Neutralizing antibodies often persist for months or longer after the infection. By the time antibody tests become positive, the molecular and antigen tests are generally negative. Therefore, antibody tests are not COVID diagnostic tests, but do provide valuable information about individuals who previously had the infection and are now recovered. Serology is an excellent tool to determine how many individuals in a population had been infected or infection prevalence. Antibody tests may provide public health with information about the level of herd immunity and provide a denominator number that will help determine the true morbidity and mortality of those who had been infected. Molecular and antigen testing will only determine individuals who currently have the virus, not individuals who had the infection in the past and now have antibody. So serologic tests may be a valuable tool to determine herd immunity and the true morbidity and mortality of the COVID-19 virus. The level of herd immunity in communities and states may be important for determining COVID-19 mitigation strategies. There are two calculations that define test accuracy: sensitivity and specificity. Sensitivity is the percentage of individuals who are truly infected who test positive. The test with high sensitivity will catch almost every infected person. Specificity is the percentage of individuals who are not infected who test negative. A test with high specificity will report a small number of false positives. The formulas for sensitivity, specificity, positive predictive, and negative predictive values are shown on this slide. There are numerous studies reported on a variety of PCR and antigen tests. The data on this table comes from several articles and provides general sensitivity and specificity information. Antigen tests like Binax have a fair sensitivity ranging from 35 to 97.4%. A reasonable clinical sensitivity figure is 72% for symptomatic individuals and 35 to 58% for asymptomatic individuals. Antigen tests have a rapid turnaround time of approximately 10 to 15 minutes. These characteristics make antigen tests a reasonable general population screening test, primarily due to the rapid turnaround time. Antigen tests like BinaxNOW are often used for regular screening of schools, businesses, etc. The rapid turnaround time allows for identification of many positive individuals, allowing them to be placed quickly in isolation. The PCR test has a better sensitivity, 66.8 to 95%, than the rapid antigen tests like Binax. But since most PCR tests require laboratory equipment, the turnaround time is longer, commonly 1 to 3 days, therefore making the PCR test less desirable to use for general population screening, since positive individuals are not as quickly removed from public venues and placed on isolation. The PCR test may have as high as a 95% sensitivity within the first 5 days of infection. The PCR test is valuable for testing those at higher risk of being infected, like individuals who are close contacts of cases, on quarantine, or are clinically suspected of being infected, like symptomatic individuals. Having said that, in practice, both rapid antigen and PCR tests are used for population screening events. Note also that the specificity of both the antigen and PCR test are 99 to 100%, which means that false positive tests for either the antigen or PCR test are very rare. A positive antigen or PCR test should be considered a true positive. Let's consider a few observations about COVID-19 RNA and replication-competent virus recovery in infected patients that informs isolation and COVID-19 testing. Concentrations of COVID-19 RNA and replication-competent virus declines in upper respiratory specimens after symptom onset. For almost all patients with mild to moderate disease, replication-competent virus has not been recovered after 10 days of symptom onset. In one case report, a person with mild illness provided specimens that yielded replication-competent virus for up to 18 days after symptom onset. Recovery of replication-competent virus between 10 and 20 days after symptom onset has been documented in some persons with severe disease, including immunocompromised patients. A large contact tracing study demonstrated that high-risk household and hospital contacts did not develop infection if their exposure to a case patient started 6 days or more after the case patient's illness onset. So even though replication-competent virus can be detected in infected patients, it may be below the infectious threshold after 6 days. This may not apply to highly transmissible COVID variants. The terms isolation and quarantine are often misused or inappropriately interchanged. Isolation guidance applies to COVID-19 infected individuals. Quarantine guidance applies to individuals who have been exposed to COVID-19 infected individuals and are under observation for evidence of infection. These next few slides review the CDC isolation and quarantine guidelines released on December 28, 2021. Individuals who are COVID test positive, regardless of vaccination status, who are either symptomatic or asymptomatic, should be placed on isolation for at least 5 days with mask wearing. If symptoms are improving at 5 days, they may discontinue isolation. If symptoms are not improving or the individual is febrile, isolation should be continued until afebrile with symptoms improving. After discontinuation of isolation, masks should be worn for an additional 5 days. If symptomatic or febrile at 5 days, remaining on isolation until 10 days after a positive test seems reasonable and practical. People who are in isolation should stay home until it's safe for them to be around others. At home, anyone sick or infected should separate from others, stay in a specific sick room or area, and use a separate bathroom if available. For severely ill or immunocompromised individuals, it seems reasonable that a clinician should determine isolation duration. For persons previously diagnosed with COVID-19 who remain asymptomatic after recovery, retesting after a new exposure is not recommended within 3 months after the diagnosis date of the initial COVID-19 infection. For persons who develop new symptoms consistent with COVID-19 during the 3 months after the diagnosis date of the initial infection, if an alternative etiology cannot be identified by a provider, then the person may warrant retesting. Consultation with an infectious disease specialist is recommended in these cases. Persons being evaluated for reinfection should be isolated while undergoing evaluation. If reinfection is confirmed or highly suspected, the individual should remain under isolation until the criteria for discontinuation of isolation and precautions is met. This is adapted from the CDC quarantine guidelines released on December 28, 2021. A close contact is defined as individuals who have been within 6 feet of an infected person for a cumulative total of 15 minutes or more over a 24-hour period. For individuals who are boosted, completed a primary series of Pfizer or Moderna vaccine within 6 months, or J&J vaccine within 2 months, there is no need to quarantine unless symptomatic. These individuals should get tested on day 5 if at all possible. A PCR test would be best since it has a higher sensitivity than antigen tests. They should also wear a mask when around others for 10 days. If they develop symptoms, they should be tested and isolate until test results are received. For close contacts who are unvaccinated, completed a primary series of Pfizer or Moderna vaccine greater than 6 months ago and are not boosted, or completed a primary series with J&J vaccine greater than 2 months ago and are not boosted, they should quarantine for 5 days and mask for 10 days when around others. If an individual can't quarantine, they should still wear a mask when around others for 10 days. Test on day 5 if possible. As mentioned previously, a PCR test would be best since it has a higher sensitivity than antigen tests. If they develop symptoms, they should be tested and isolate until test results are received. Among Kentucky residents infected with COVID-19 in 2020, vaccination status of those reinfected during May to June 2021 was compared with that of residents who were not reinfected. In this case-controlled study, being unvaccinated was associated with 2.34 times the odds of reinfection compared with being fully vaccinated. In the August 13, 2021 MMWR article, the CDC stated, a study of COVID-19 infections in Kentucky among people who were previously infected with SARS-CoV-2 shows that unvaccinated individuals are more than twice as likely to be reinfected with COVID-19 than those who were fully vaccinated after initially contracting the virus. These data further indicate that COVID-19 vaccines offer better protection than natural immunity alone, and that vaccines, even after prior infection, help prevent reinfections. Reinfections have been increasing, even for fully vaccinated individuals. This has particularly been seen with new COVID variants. The risk of reinfection may be lower in the first 3 months after the initial infection, but may increase later, likely due to waning immunity and genetic drift associated with viral variants. In summary, epidemiologic data is critical for effective pandemic planning. Flattening the curve prevents overwhelming healthcare systems. Screening and diagnostic testing is important. Serologic testing provides information regarding herd or community immunity. Compliance with isolation and quarantine guidelines is essential.